And I'd like to welcome Dr. Sally Hull, who is one of our local GPs and an honorary reader in primary care, along with Helen Rainey, who's our lead CNS for CKD in education with us at Barts Health. And they're going to be talking to us about working with primary care. Thank you very much.
Thank you very much. Yeah, so I've been a GP in East London for a long time and also work at the Clinical Effectiveness Group in Queen Mary. And this is essentially a quality improvement organisation which supports practices across the whole of East London. And importantly, for the purposes of this afternoon, the CEG holds coded GP data from the 1.3 million population across inner East London. Next slide, please. The East London Community Kidney Service model has got three main parts. The first part on the left deals with population health data, and it identifies coding and primary care management. And we can do this both at CCG level and at primary care network level, and we can drill down to practices. And we develop these each quarter, and they're sent out to CCGs and to the renal department. The second part is what we call trigger tools, and these are really a safety net which flag up to practices patients who've got a falling EGFR. And the third part on the right is the virtual clinic, which I'm not really going to mention today, but which has full access to the primary care patient record with patient consent. And nephrologists can write their answers to queries in the GP notes. And it's really like an extreme form of advice and guidance, and less than 10% of patients need to have a face-to-face appointment. Now, as of course you know, most CKD is identified in primary care, and most cases are associated with other long-term conditions. The next slide, please. And whilst it is pretty unusual for a GP not to code a patient, say, with diabetes, we know that a lot of CKD remains uncoded. The National CKD audit in 2017 found on average 70% CKD coding, and that was amongst volunteer practices. There, right. Now, what you'll be able to see when that stops, is firstly that the average is improved, but also the dramatic journey taken by some of these practices, which have improved from 20% coding. The tracer plot shows that, from 20% to 90% coding. And of course, improved coding is associated with better blood pressure management, more use of statins, and preventive activities such as flu and pneumovac. Next slide, please. Alongside the CKD coding, our quarterly dashboards also look at blood pressure management and statin prescribing. This is a dashboard from March 2021, so very recent, and of course is slightly misleading because a lot of the patients couldn't come in and have their blood pressure measured. But the reason I'm showing it to you, because we've managed to disaggregate the age ranges, and what we can see is that there's less CVD intervention amongst some of the younger groups. And this has to be a target area for improvement for the future, because they're the group who will most benefit from use of statins and blood pressure management. Next slide, please. The falling EGFR tool acts as a safety net, and it's run monthly in practices as it has named patient data. As a very busy GP, it's very easy just to look at the latest EGFR value. And what this tool does is to encourage clinicians to look at the trajectory of the EGFR. Next slide, please. This slide shows a practice-facing view of the trigger tool. And you can see that on the left is the patient name, and then the next section shows the latest EGFR done that month, and the next bit shows the previous EGFR and the fall in EGFR, and it'll only flag this up if there's a fall of 10 or more. And we encourage GPs to put in a reflection on their clinical management, and that bit can be stripped out and be used as an audit for their PDPs. Next slide, please. As part of the service evaluation for the East London service, we reviewed approximately 2,000 trigger tools. And what this showed was that approximately 8% overall are referred, and that 2/3 had a very appropriate comment about managing, changing medication or reviewing patients or repeating tests. We also found that some 50% of falls in EGFR were greater than 15 units. And finally, we also noted that younger patients, those under 60, had similar rates of referral into the service to patients over 80. Next slide, please. So just to pull this together, maintaining improvement in primary care needs a resource. And the model that I'm showing you here is very data heavy and needs analytic capacity. But what we also need is community nephrology teams, because continuous education and continuous support is needed. And finally, whatever model is used, it should integrate with local GP systems and be simple to use. As one of my GP colleagues says, you've got to make the right thing easy to do. Now, our final slide is one that Helen is going to talk to.
Thank you, Sally, and thank you to the London Kidney Network for inviting me to speak. I'm Helen Rainey, and I'm a kidney nurse at Barts Health, and I'm going to share some of our findings about the patient and practitioner education components of our community kidney service. Sally has shown the improvements in coding of CKD that have been achieved in East London. Alongside this increased awareness of CKD, we've seen a large increase in referrals to the renal service, with the majority of patients being managed with advice to their GP and not requiring a nephrology appointment. This has enabled us to know about many more patients who have early CKD, and we felt that there might be a benefit in providing education directly to these patients to help slow the progression of their disease. There are accredited education programs for people with diabetes, but we do not have anything similar for CKD. At Barts, we developed a patient education session which explains CKD in the context of other long-term conditions and which focuses on reducing future risks. Our evaluation showed that providing CKD education in this way led to increased knowledge and can motivate behaviour change, but could also lead to increased anxiety. And one concern is that many patients haven't subsequently discussed their CKD with their primary care team, and one of our priorities is to try to address this. Practitioner education is another important component of the community kidney service and may help to support practitioners to feel more confident when talking about CKD with their patients. We've provided 75 practitioner education events over 5 years, although it's important to acknowledge that there's potential for learning on both sides and from every interaction between primary and secondary care. We've tried to reach everyone who's involved in CKD care, from healthcare assistants who are involved in screening through to practitioners who are responsible for the management. And again, our emphasis is how CKD often occurs alongside other long-term conditions. A major challenge has been that the education sessions have been quite ad hoc, and they depend on the priorities and the time available in primary care, as well as our availability. Our practitioner survey findings showed that whilst education sessions are viewed positively, there are concerns about the time and sometimes a view that CKD management is extra and unresourced work, which we need to be mindful of when we're planning our services. But I'd like to finish with a comment from a practice nurse who was given to the question, has the education session changed your practice? Yes, I now include self-management of chronic kidney disease in part of diabetes and hypertension reviews. Thank you.